Hi, thank you for joining us for Pillars of Obesity Management. What can we learn from other national guidelines? My name is Phoebe James, and I am a Professional Development Officer with the PHN. Before we go any further, I would like to acknowledge the traditional custodians of the lands we are all meeting on today and pay respect to elders past, present, and emerging. I just wanted to mention before we start that this session is being recorded. The recording and the PDF slides will become available on the PHN website in the Education Library in the next few days. We are having a Q&A session at the end of the presentation. Please feel free to put your questions in the box on the right-hand side of your screen. Presenting tonight, we have Laureate Professor Claire Collins and Dr. Rebecca Williams of the University of Newcastle. At the end of this presentation, there will be an evaluation which will be located underneath the polls tab in the box on the right-hand side of your screen. And if you want a certificate for this session, the evaluation will need to be completed. I will now hand over to Claire.
Good evening, everyone, and it's great to be back to talk to you again tonight about weight management guidelines. So I think I'm just waiting for the slides to come up. Yep, thank you. So what we're talking about tonight is some of the pillars of obesity management and what can we learn from other national guidelines. Here's our learning goals for you tonight: to understand the evidence hierarchy that's used to inform clinical guidelines, to have a look at some of the latest evidence for obesity management strategies, and to be aware that one size does never fit all when it comes to weight management, and to understand the role of the dietitian and how the dietitian can contribute to improving nutrition and weight-related health. Often you hear in the media, especially the social media, how much we all disagree. Should we be following keto, low carb, no carb? Well, there's actually more that we agree on than we disagree on, particularly when it comes to health professionals. So here's some of the things that we agree on. Number one, that dietitians are an essential part of the healthcare team members. And you might think, well, why does it even have to say that? Of course, we already know that. Well, when you look at the data from the Australian Bureau of Statistics on chronic disease management plans, or the enhanced primary care plans, of all of the referrals to allied health, depending on which year you look at, dietitians see about 1 to 2% of those. So we're not a heavily utilised allied health member when it comes to chronic disease. We all agree that nutrition practice should be evidence-based. That dietitians should support people to improve their nutrition-related health and well-being, and that nutrition interventions need to meet the client's needs, and importantly, do no harm. So I'm going to show you some of that latest evidence. I'm going to give you a little bit of homework, and then Rebecca's going to talk about applying that in terms of evidence-informed practice. I'm sure you're aware of the research evidence hierarchy, so that when guidelines are put together, they're not just plucked out of the air. Well, I think it should be this, or I think it should be that. Most guidelines today are informed by not just randomized control trials, but systematic reviews of randomized control trials. And that's why they're at the top of the evidence hierarchy there, the meta-analyses. And what a meta-analysis is, it's when you can combine the results from a number of randomized control trials that have reported outcomes in the same way. So in the context of weight management, they've probably reported the percent weight reduction or the percent body fat change, and they can be mathematically added together in what's called a meta-analysis. It's really like mathematically creating all the trials temporarily as though they're one big trial, and then very, very powerful. You can see that what's at the very bottom of this pyramid, and what there is lots of, is things like textbooks, encyclopedia, and you can put public opinion. When there absolutely is no research evidence, sometimes expert opinion will be used to interpret the research that's out there when guidance is needed. But in general, we look for the top of this pyramid informing evidence. So tonight we're mostly focusing on evidence that's been captured in the Canadian Obesity Management Guideline. They're the most recent guidelines internationally. And so there's two ways in which that evidence has been evaluated. Number one is the category of research evidence, using those evidence levels from that expert opinion down at level 4, right up to those meta-analyses that are considered level 1A. And then the strength of the evidence. And the strength depends in part on the type and the quality. There's no point having a whole bunch of randomized control trials if they're really dodgy. So if the methods are very poor and there's a lot of bias. These numbers and letters are used differently in the Canadian obesity guidelines compared to NHMRC and Cochrane. But what you're looking for is A's and 1s, essentially, in that kind of rank order. So ideally, evidence-based practice would be based on level 1, grade A research. So we're going to keep our eye out for that, and we'll talk about why that's not always possible. If you remember, we used to have NHMRC weight management guidelines, and they've been rescinded. And why are they rescinded? Well, actually, they were out of date. So they were released way back in about 2012, but there were still some key messages informed by high quality evidence in terms of what the key messages are that still hold up. And they were that when a patient is ready to attempt weight loss, aim for a 10% loss of body weight initially. And I think for many people, this was actually a bit of a revelation, because typically people engaging in weight loss would like to lose 30 or 40%. But all of the trials that are informed by the diabetes prevention programs have shown that realistic over 10 months is having a 10% initial weight loss goal. And what the 4 key diabetes prevention trials around the world showed, that is if at 2 years a person has kept off a 5% weight loss, then the reduction in risk of developing type 2 diabetes over that period is more than 50%. So this is a key message, that losing 10% is outstanding to achieve that. When you look at the meta-analyses of these trials, it actually was 7 to 8%, but they rounded up to 10% because that's easy to calculate as a percent of someone's starting weight. And the aim then, the main dietary advice in these 2012 guidelines from NHMRC were to decrease energy intake and aim for a reduction of 2,500 kilojoules per week. That's like around 600 calories per day, rather. So, it was pretty basic evidence for diet. And anyway, now they're rescinded because, there's more than, 12, 13 years of research evidence that they don't include. So at the same time, in parallel to NHMRC, my team led, on behalf of my profession, Dietitians Australia, a review of nutrition strategies to address what we saw as a gap, just saying, eat less kilojoules, to looking at what the research evidence had said. But look, that was 2011. So, again, like more than 10 years of research evidence hasn't been included in that. So then released earlier this year was the National Obesity Strategy, which includes a commitment to reviewing clinical guidelines. And I believe that there actually is a scoping for new updated clinical guidelines as part of that. And that was released. And the reason why the National Obesity Strategy, which was commissioned, which has a very big focus on prevention, is, I don't know if you can read this teeny-weeny writing there, but the direct healthcare costs due to weight-related health is more than $5 billion a year in Australia, and that's in the direct costs. So, given that weight affects many chronic conditions, let's just broaden that question a little bit and ask, what nutrition strategies work for obesity and chronic disease management? So that's predominantly cardiovascular disease and type 2 diabetes. So we need to then know, well, what nutrition strategies work to improve health and well-being. So yes, you want to improve your health, but if that makes you so miserable or triggers adverse mental health, then you have to ask, is it really, really worth it? And what's the point of helping you feel better if you don't get a health gain? And as most of us know, that they're very interlinked. So medical nutrition therapy can support weight loss, and behavioural counselling is important for weight loss, and all of those are integrated. So we're going to also touch on the role of the dietitian in the case studies. So here's the website link for the Obesity Canada guidelines. The guidelines themselves are about 800 pages. So, like if you're having trouble sleeping one night, just download the whole thing. And I guarantee you'll get to sleep pretty quick. Just jump into one chapter at a time. But the good news is when you go to that website, you can actually download a summary which gives you all the key points, all the highlighted evidence statements for weight management. But, all credit to Obesity Canada. It's an amazing resource, and I wouldn't be surprised if it's not utilised when we get to revising Australian guidelines. Now, when you go in and look at Obesity Canada, there's specific chapters for every allied health discipline and absolute lot of information. So there's a whole chapter devoted to medical nutrition therapy, which we never had in the NHMRC guidelines. So see how teeny weeny that writing is? I'm going to give you a test on this at the end to see what you remember. No, I'm actually just joking. All I want you to be able to do is just get the message this.
Hi guys, we're obviously just experiencing some tech issues, so please just bear with us.
Well, I know it's not my fault.
Oh, we seem to be back.
Great. Well, I know it's not my fault because I didn't touch anything. So all I want you to see is that, yes, there is some level 1A, grade A statements when it comes to medical nutrition therapy. And there's even some level 2. And I didn't really expect that. So I'm just going to zoom in on those for you. So I've just summarized in each of these upcoming slides. Don't panic. If you want to know the wording in each of those recommendations, that's a summary of the evidence, you can download the medical nutrition therapy chapter. But this is the key thing from the highest level of evidence, is that adults living with obesity should receive individualized medical nutrition therapy from a dietitian to improve a range of outcomes. I can see there's obviously some internet issues, which is, I can promise you, is not coming from me because I'm plugged into a node. Adults living with obesity and pre-diabetes should consider intensive behavioural interventions targeting that 5 to 7% weight loss long-term to improve a range of outcomes. And adults living with obesity should consider intensive behavioural interventions targeting 7 to 15% if the goal is type 2 diabetes remission. Okay, so that's an update. So if the target is type 2 diabetes remission, then essentially it's aiming for a larger percentage weight loss. And something that's a unique contribution of the Canadian obesity guidelines is really they've tried to answer that question, who should attempt weight loss and when? And this tool's called the Edmonton Obesity Staging System. And what it does, it marries together in this little left-hand box the World Health Organization classifications of weight status for the different categories of obesity, from class 1, where BMI is between 30 and 35. And we all know that BMI is only a very broad scale classification because it does not factor in muscle mass and it does not factor in ethnicity, where BMI can be related to ethnicity and a larger lean mass, a larger muscle mass. So what it does, it asks both BMI, and then it actually asks about the degree of impairment. So physical impairment, psychological impairment, or functional impairment. So let's look at what it says there in stage 1. I'm going to go on a bit close because that writing really is tiny, but we'll come back to this tool. So all you need to remember that someone could have a BMI that actually says, oh, you're in the obese class 1 category, but they have no sign of obesity-related risk factors. They don't have high blood pressure. They don't have impaired glucose tolerance or any indicator of high fasting glucose. They don't have elevated lipids. They have no physical symptoms. They have no psychological impairment, and they have no functional impairment. So the recommendation is there is no need to recommend weight loss for this person. And you'll see it starts to progress through to stage 4 impairment, where someone is severely or considered at end stage due to the obesity-related health complications. They have a severe psychological distress or psychological conditions and physically impeded by their weight status. And you can see the case study down the bottom. That's really, really teeny writing, but this essentially is somebody who's presenting wheelchair bound due to their inability. Great, thanks. That's easier to read now, isn't it? BMI 54, disabling arthritis, severe hypnea and anxiety disorder. And this is where like comprehensive support would be required to try and help that person improve their quality of life by improving their weight-related health. So you can keep that in the background. And clinically, that is actually a really useful tool to have in your practice. So you can talk that through with patients. Okay, so going back to that complicated slides with the 20 plus dietary recommendations, the middle one where it says zoom in for more recommendations, adults living with obesity can consider any multiple medical nutrition therapies to improve their nutrition-related health outcomes, choosing dietary patterns or food-based approaches that support their best long-term adherence. This has to be something that works for the patient or client. So then when we drill down into more specific types of diets, just look to see if there's any green. And the highest evidence on this slide, there are some green statements, thank goodness. More recommendations. You really wouldn't want there to be a test, would you? How would you remember all of that? But now for the DASH diet, for example, we have level 1, grade B evidence, and lots of green, lots and lots of grade 2 evidence. So how do you summarize that? Well, thank goodness the Canadian obesity guidelines come to the rescue. So this is the main message that I want you to get. See this chart across the top. Here are all the weight-related risk factors and dietary-related risk factors. Here's all the types of nutrition therapies listed in those guidelines. And here where there's evidence that this approach works. So if you just scroll down here, look at all the types of dietary approaches that work for weight management: medical nutrition therapy, intensive lifestyle therapy, kilojoule or calorie restriction. So really the key message is that there are many nutrition interventions that work to influence weight and health and quality of life indicators. The best approach is going to be the one that an individual feels they're able to maintain long-term to achieve that health gain, and it can change over time. And this is just summarizing that. And some of you will have participated in the two online presentations Rebecca and I did last year, where we went into great detail about the hierarchy of energy restriction. So with every dietary intervention, choosing those, it's helping the person to work out the stage of change, what are their priorities at this time, What progress do they make over time? And then when they reach their initial goals, how do they feel about their ability to maintain or adhere to what they've done for weight loss? So keeping in mind what we've said along in our previous presentations is current dietary patterns in Australia are a shocker. More than 1/3 of what people eat comes from the discretionary choices, plain language, junk food. So always helping someone work back towards boosting their vegetable, fruit, and whole grain intake will have the biggest impact on their nutrition-related health. And then beyond that, it's selecting the level of energy restriction that's appropriate given the current case. And you might want to link back and look at that. But wait, there's actually more. So you might have noticed that I said that the Canadian obesity guidelines, the evidence only went up to 2018. So I went looking for systematic reviews. Okay, there's a lot of things discussed in the literature about low-carb diets. What systematic reviews have the Canadian obesity guidelines missed out on? Because these might be things that a patient or client will come in and ask you about, ask your opinion. And don't take any notes because you're getting a copy of these slides and the presentation will be on the PHN website. So I'm going to take the same approach and give you a summary of this, but I just want you again looking for red and green in that evidence grade and conclusions. So in 2021, there was a systematic review of low carbohydrate diets for type 2 diabetes. And up the top in this review, they defined low carbohydrate as less than 130 grams a day or less than 26% of energy. Now, the Australian Dietary Guidelines recommend anywhere around, say on average, around 50% of energy. So this is like about cutting down your carbohydrate by about half of what you usually eat. And in terms of HbA1c, look, there's high quality evidence that up to 6 months, a low carbohydrate diet will actually improve HbA1c. And then the evidence falls at 12 months. But, for getting someone started, a lower carbohydrate diet, like 50% of what they normally would consume, that might be reasonable for some people, but particularly if that low carb comes from dropping the junk foods. So the conclusion, moderate level of evidence supporting adherence to low carbohydrate diet with concurrent weight loss, effective for type 2 diabetes remission at 6 months, but it wasn't actually significant at 12 months. So only moderate at 12 months. Okay, what else was in the literature? So this systematic review was on how much carbohydrate should you eat for the management of type 2 diabetes. But this time, this was really a lower carbohydrate diet because this time they've defined it as less than 40%. So remember on the last slide, it was less than 25% or half of what current dietary patterns are. This time it's just reducing it, but not going quite low. And this time, I hope you can see that there's actually no green at all. So the message from that was there's moderate level of evidence for no difference between lower and higher carbohydrate diets for weight loss, HbA1c or triglycerides. Energy balance was the cornerstone for general management of diabetes. Next one, weight neutral versus traditional weight loss approaches. So this is where you actually don't discuss weight at all. And the key thing here is there is no green and there is no yellow. So let's just go straight to the conclusion. No strong level of evidence for weight neutral over other weight management approaches. One exception, patients with bulimia. So if there's disordered eating in the category of bulimia, then you would refer that person for psychological support to discuss their disordered eating. One category of weight neutral approaches is called health at every size. So we also found an RCT, an additional randomized control trial. So we included this ourselves and again as an extra and analyze them together. So predominantly red, one yellow around cardiovascular risk factors. So Hayes-based interventions were effective in improving some cardiovascular outcomes, total and LDL, but there was no significant difference between groups in included studies. One approach not significantly better than the other. And I just want to point out that this review, a major fault of this review was that they didn't actually extract the between group difference, usual care versus the Hayes approach, which is what you generally would do. They just looked at each group from baseline. So we went back and extracted it. The next question people often ask is, well, it's way harder to keep weight off than it is to lose weight initially. And what the literature says here, that health professionals do need to advise clients on that unless there is a specific weight loss maintenance strategy implemented following that initial dietary approach for weight loss, then rebound is to be expected. It kind of makes sense, doesn't it? If you think about someone with hypertension and you put them on antihypertensive therapy and then you stop it, you wouldn't actually expect them to remain normotensive, would you? So it's kind of the same. If you put someone on to a weight management strategy and then you stop it because they achieve the target, well, then it can't really be surprising that weight comes back. So, but which type of intervention for maintenance is unclear. The key message is that doing something rather than nothing. So if you've got patients who've initially lost weight, encourage them to think about what could they do next. Do they need to join another program or do something different again with their dietary strategy, or periodically check in, a bit like spring cleaning your house, coming back and restarting periodically? Or are these clients for whom you might introduce a medication once it feels like it's too hard to stick in this maintenance period? There's all options are there and for you to discuss with your clients. Okay, come on button. Okay, so what about dietitians? Is there any evidence that we do a good job? Well, at least it's yellow. There's moderate level evidence, and part of the challenge is there aren't as many studies that are led by dietitians. But individualized consultations with a dietitian did achieve significantly greater impact on weight control compared to usual care. And there is also cost-effectiveness evidence showing that being referred to and managed by a dietitian can reduce healthcare costs compared to usual care. Okay, so how do you incorporate this evidence into medical nutrition therapy practice? Well, now I'm going to hand over to my colleague, Dr. Rebecca Haslam, to take you through that.
Thank you, Claire. So for the next section, I'm going to focus more on how do we actually apply the evidence that Claire's just really nicely summarized for you. So how do we apply that? How do we apply the obesity management tools that we have, and how do we apply them to clinical practice? So I'm going to step you through the patient journey in obesity management, and I'll step through each of the 5 steps in a little bit more detail so that you can see how we would move a client through this journey. And then I'll also finish off with a couple of case studies so that you can see it all come together as well. 2 of the main points to consider when we're looking at obesity management and moving a patient through this journey is that we always need to be taking a patient-centered approach. So ensuring that firstly we're asking permission to discuss weight, that we're taking into account the individual's needs, the types of goals that they want to be reaching, to ensure that we take a collaborative approach to their intervention strategies. The second thing is around ensuring a multidisciplinary approach. So if we really want the best outcomes for our patients, we need to be engaging each of the key health professionals that can really play a role in each of the different aspects of obesity management care. So, working through steps 1 and 2. So as I mentioned, patient-centered care is a really important part of obesity management. So it helps to form that relationship between the patient and the provider, and it helps to build that trust. So we know that if we're able to build that trust with the patient, then we're more likely to have longer-term success with their obesity management. It can be as simple as just asking, is it okay if we discuss your weight today? Because despite sometimes what we think or what a patient may actually be referred for, it may not actually be their goal to actually lose weight when they're coming in for a consultation. So we're always taking a collaborative approach with obesity management. Then we're moving on to step 2. So we're assessing their story. This is where we really start to gather as much information about them as an individual as we possibly can, because all of this detail really helps inform the best strategies that we can implement. So we take into account their story, their information, along with the evidence that we have at hand to ensure that we're really putting a personalized intervention in place. When we're collecting this information, we're also assessing anthropometry. So we're collecting height, weight, waist circumference. We're then calculating BMI so that we can look at the obesity classification. And then we're also asking questions around risk factors of chronic disease or comorbidities so that we can then assess the Edmonton obesity stage that this particular patient is at. So as Claire mentioned, there's 5 stages in the staging system. Stage 0, the primary focus really should be around diet quality and behavior change. Whereas once we're moving into stage 1 through to 4, on top of that, we can then also look to include some weight loss outcomes as goals at the same time. And when we move on to step 3, we're looking at how we're then going to advise on the management of obesity, but also potentially comorbidities at the same time. So initially, we'd be assessing the patient's readiness to change. If the patient isn't ready to change, we're not going to be able to progress into setting goals around their weight management or around any other potential risk factors. So instead, we might be focusing on educating them on the diet-disease relationship so that they're more informed of how their current behaviours are influencing their health status. Or we could also be evaluating the pros and cons of change. So if we can really start to get them to realise the benefits of change, then hopefully it's going to help them move along the stages and get them to a point where they're actually ready to set some goals and make some changes. Once the patient is ready to make changes, then we can really start to tease out what are the key nutrition messages that we need to be educating on. And then one step further, what is the medical nutrition therapy and potentially the exercise recommendations that we need to be making to ensure we're actually starting to address their weight and their health needs. An important consideration here as well is that this can be where the multidisciplinary approach really comes into play. So if we look at the other aspects to obesity management support beyond nutrition and physical activity, then we can also be looking at psychological support, medications, bariatric surgery, each of those requiring different health professionals to be involved. So there might be some overlap within the psychological section that dietitians have scope of practice to cover. So we might be able to help them manage stress or sleep better. But once it goes beyond that, then we need to be referring on to psychologists. If there needs to be discussions around medications or bariatric surgery, then we're coming back to the general practitioners. We're coming to the surgeons for those discussions as well. So when we're looking to work out what medical nutrition therapy is best for this individual, we're taking into account all of the other information that we've also collected in that data gathering phase. So that, again, we're making sure that we're taking a patient-centered approach. We're making sure we're taking into consideration different individual characteristics and needs. And then, of course, we're then also using the evidence that Claire's summarised to know perhaps what is the best medical nutrition therapy approach that's going to suit the particular weight or health outcomes that we're trying to address. And I'll come back to the monitoring and evaluation in a second. So then we're moving on to steps 4 and 5. So step 4, we're agreeing on goals with the patient. So that's where we're collaborating with the individual to ensure that we're both on the same page. We're in agreement with what that action plan is going to be. We're clear on the goals, and we're comfortable that the goals and strategies actually align with their willingness to change and the things that they're actually able to do on a day-to-day basis. Then we're also assisting with the drivers and the barriers. So this is often done when we're doing follow-up consultations. So we might be evaluating how the patient has gone with the original goals and strategies that we've set. Maybe there's been a couple of things that have worked really well, and they're the drivers that are really going to help this person stay motivated and stay on track to reach their goals. But perhaps there's been some other things that have gotten in the way. Maybe there's some time barriers or financial barriers that are preventing them from actually implementing the strategies that we're putting in place. So being able to have regular visits with patients can certainly help with their progression to overcome any hurdles and build their self-efficacy to be able to self-manage and know how to come up with strategies to overcome those barriers. As Claire mentioned before, when we're setting these goals, there's any number of dietary strategies that can help us reach the same endpoint when it comes to weight or health outcomes. So it's coming back to, again, what does the individual feel is going to work best for them in their obesity management? So moving on to a couple of case studies. So I've chosen this first case study because it's definitely an interesting one that I do see a lot more in practice. So this particular case, BMI of 27.8 and no comorbidities. So what is the Edmonton stage that this particular patient sits or falls into? So we know because of the BMI category and there's no comorbidities, we're in stage 0, which means that the primary focus should really be around diet quality and behavior change. The next step is then the data gathering. And the interesting point about this case, which I'll explain in more detail as we go, is that this particular case actually attends the visit because she actually has a goal of losing weight. So this is a really good example of how a patient-centered approach can come into the intervention, how we need to really be paying attention to what the patient wants as an individual, but also having the opportunity to discuss the different options, the range of strategies that are possible so that the patient has greater awareness of what options there are actually to choose from. So her recent bloods were clear. She does have a history of weight cycling. She notes hunger across the day, and she tries to restrict intake early in the day in order to help with weight loss, but her willpower falters by the afternoon, and that's likely due to undereating earlier in the day and the stress of work and family commitments. She works at a bank and walks the dog 4 days a week. So we can already start to see that there's some information that we've gathered that's really going to help inform our intervention moving forward. In the diet history assessment, we've got adequate intake of fruits, grains, and dairy, but inadequate intake of vegetables, meat, and meat alternatives. She has inadequate intake early in the day, but episodes of overeating later in the day. And this overeating tends to be those discretionary choices. So we know that we've got excess kilojoule intake coming from the overeating episodes. So again, we can see that there's some behaviors that this case or this patient has day to day that could certainly be improved, which may inadvertently then help with the weight loss goals that she's after. So what intervention approach do we take? As we've said multiple times, there's lots of options that we could take. It is discussed with this particular patient that there are a couple of approaches that we could take. So we could have weight as a primary outcome or a primary goal that we're focusing on. But given her history of weight cycling, then we have the discussion about whether that's worked for her in the past and whether that's really the best intervention moving forward. Instead, after discussion with the patient, we actually decide that the main focus, and this again realigns with that stage 0 of the Edmonton scale, the main focus is going to be on diet quality and managing her hunger or her overeating, which, as I said, could then inadvertently lead to the weight loss that she's after. But we're not actually going to have weight loss as the primary goal that we're focusing on. So the goals included food-based approaches. So from the dietary assessment, we know that there are a few food groups that she was falling short on, so we can improve the quality there. And we can also improve the quality by reducing some of those discretionary choices. And we can limit the episodes of overeating by modifying her current behaviors, which is really trying to restrict intake earlier in the day, which then flips later in the day where she loses willpower, and that's when she starts reaching for those discretionary choices. So the specific strategies that we've decided to use. So we're going to be focusing on increasing vegetable intake because that was one of the food groups that she wasn't meeting. So we're going to be including vegetables and salad at lunch and dinner, as well as some snacks. So to increase the volume of intake, but with lower energy density and extra fiber. So we're really improving the quality of her intake here. We're also including more meat alternatives, which have a higher amount of protein. So we'll include these across the day. The higher protein intake is also going to help manage her appetite across the day. And the third strategy is more working along the mindful eating approach. So we're really going to start to get her to tune into her hunger and fullness cues as a way of determining when she needs to eat and stop eating across the day. We want to make sure we're really setting some good monitoring in place as well, because we know often with a patient like this, there's going to be some potential barriers. One of the bigger barriers with this particular case is what we call associative learning. So that's when we have repeated exposure to food because it's being used as a method to reduce stress. So we know in this patient's case, she was using food a lot to help with stress and family commitments. So when you have that repeated exposure and using food as that method of reducing stress, it generates a conditioned wanting every time that this particular patient is under stress. So this may be where we need to be bringing in some of our multidisciplinary team. So we may need a psychologist to help with some alternate stress reduction techniques, some strategies for reducing emotional eating. So we need to be considering it and having that discussion with the patient, whether they're actually on board with us referring them to a psychologist. The monitoring, so we did agree that the weight would not be the outcome that we were focusing on over time, but instead other health indicators would be monitored instead. So often we can use some cognitive variables, some other sort of wellness scores and things as well. And often we just get patients to rate those on a scale of 1 to 5 or a 1 to 10. And we can measure those or track those over time as well to ensure that the strategies that we're putting into place are actually having the desired benefit that we're after. So overall, with case study number 1, we really would have been improving diet quality because of increasing the particular food groups that we did and reducing discretionary choices. And potentially, we may have also seen a decrease in weight over time because of those changes as well. And hopefully those behavior modifications and working with a psychologist may actually also help to change some of those behaviors and break that pattern of the weight cycling that particular case has experienced over time. So moving on to case number 2. So now we have a BMI of 33.9. This case also has type 2 diabetes and hypertension. So again, which stage are we classing this particular case at? Because of the BMI classification and also the addition of health conditions such as type 2 diabetes, this is the Edmonton stage 2. So weight loss should be advised along with the management of the comorbidity. So the data gathering for this patient, so they've attended the visit because they want help with their blood glucose control and weight loss. So they have had recent bloods and their HbA1c was above 7%. This patient is also quite sedentary, so has a sedentary job and does no purposeful activity either. With the diet history, we have adequate intake of fruit, meat and alternatives, dairy, although it's full fat dairy, and also grains, but inadequate intake of vegetables. This patient also has excess of discretionary choices, and that mainly comes from 3 to 4 takeaway meals per week, which we know are going to be higher in salt and saturated fat. On reflection, his diet also contains a lot of high glycemic carbohydrates and quite poor timing of his carbohydrate intake across the day as well. So we can see already when we're looking to manage weight and we're looking to manage the comorbidities as well, we've got a few things here from the diet history assessment that we can start to work with. So what is the intervention approach going to be? So after discussion, and it was agreed by the patient that they're happy for the main focus to be 1, calorie restriction, and to make some dietary changes that align with the DASH diet. So both of these are going to help with weight loss and also management of glycemic control and hypertension. Also, for this patient, we're going to do a little bit more education on the relationship between current dietary intake and type 2 diabetes and hypertension, just to ensure that they have greater awareness of how their current dietary practices are impacting on their health status. So the goals for this patient included a 7% weight loss over a 4-month period, and that was the equivalent of around half a kilo per week. So our calorie restriction was really around that sort of 2,000 kilojoules per day that we're going to be creating a deficit, and then also reducing HbA1c under 7% in that period of time. So the main strategies, one of the main ones is going to be around carbohydrates, so addressing the quality, so reducing those high glycemic carbohydrates down to low to moderate, as well as evaluating, looking more closely at the quantity and the timing and putting some specific strategies in place around that. Then also incorporating key components of the DASH diet. So we're going to be swapping full cream milk to light milk for his daily coffee, and also using reduced fat over full fat cheese, replacing more of the processed meats that he has quite a high intake of, so mince and sausages with more lean sources of protein, plus including a serve of nuts each day, and not adding salt at the table. And then when we're looking at energy restriction, we're aiming for more home-cooked meals throughout the week, so less takeaway, and also including some physical activity. So a couple of days a week, this patient's agreed that they're happy to work to and from work, walk to or from work. So it's only a 10 or 15-minute walk either way, and also include a 30-minute bike ride on the weekend. And then we also know by swapping from the full fat to reduced fat dairy, and then also moving to more lean protein options is also going to contribute to that energy restriction as well. So potential barriers for this particular patient. So we know they had quite a high intake of takeaway meals. And on discussion of that further, it's been identified that it's just the easier way to go. So time is often quite a barrier for this particular patient. They're busy, they work quite long hours in their job. So getting takeaway on the way home is the easier option for them. So that's a potential barrier when we're looking to increase home cooked meals. So there's a lot of education around how they can use convenience options to easily, quickly prepare some healthy meals. But the next consideration could also be around some pre-made dinner meals, an option like light and easy. When we're monitoring with this patient, so it's good to have a bit of a structured plan in place so we can monitor progress more closely. So a potential structure could look like 2 fortnightly visits to monitor the weight barriers and drivers to change. And in this time, does the weight loss strategy need to change? So coming back to this hierarchy of energy restriction, we've gone for a more moderate approach to start with, but do we need to move down the hierarchy here if we're not achieving the outcomes that we are after, but also keeping in mind that adherence may then become an issue? Then we'll also add in a few monthly visits as well, and then a follow-up blood test down the track as well to retest HbA1c and ensure that a lot of the dietary strategies that we've put in place, the additional exercise, have all improved both weight and the associated comorbidities with this particular patient as well. So that's the end of my section as well. So a little bit of homework for you. So this takes into account all of Claire's section as well. So we'd love you to read the Canadian Obesity Guidelines. But as Claire said before, it's quite an extensive document. So, if you're looking for an option to read when you're lying in bed to help you go to sleep, then for sure read the whole guidelines. But definitely take the key snippets out of it and use a lot of Claire's summaries that she's given tonight to help you better understand where the current evidence base is when it comes to obesity management. Use the systematic reviews and meta-analyses to enhance your knowledge, and always seek professional development opportunities for behaviour change counselling. So we know that that's definitely a big part of where we all need to be moving as health professionals, is to help individuals overcome those barriers to change and move them along the readiness to change, and really help them build that internal or that intrinsic motivation to want to change and build self-efficacy within themselves as well. Take-home messages. There's a variety of medical nutrition therapy approaches that can, again, get to the same endpoint of the weight outcomes and health outcomes as well. Use the 5 A's, so those steps that we've worked through with individuals to select the most appropriate intervention. Use personalised approach to assist the individuals improve their diet-related health and well-being. So again, there's no one size fits all, and it really does come down to us being able to ask questions and listen to our patients to ensure that we're really giving them a personalised approach that suits them and their individual needs, and advocate for greater access to medical nutrition therapy services. So we know that dietitians don't get enough referrals for medical nutrition therapy, and this is something that we would definitely like to change within our profession. So thank you from both Claire and I think we've got a bit of time for some questions.
Thanks, Beck. And we've got plenty of time for questions. And hang on, there's one from a general practitioner, but I too just want to give a really big shout out first up to the Obesity Canada Guidelines, because one of the topics that it addresses that you don't see discussed very often unless you participate in some of the obesity special interest groups or groups like the Obesity Collective is a discussion of weight bias and stigma. And I'll just tell you what number chapter it is. So it's actually after the summary, it's actually the first chapter in the Canadian guidelines. And I know when I discuss this with our students who are going into their final year, is I gave them 2 online stigma and bias surveys to do. And I think a lot of people were really surprised. And even in myself, it's really good to remind yourself that you can be contributing to stigma and bias. And we have an online program, The Science of Weight Loss, which we had assessed by consumers for the presence of stigma or bias to ensure it was non-stigmatizing. And then someone has kindly posted, and I've accidentally moved it to archive. I was trying to star it, a link on the general practice site that now provides additional information about how to have those healthy conversations as well. And the 2 courses that we ran in collaboration with Western Australia that we advertise regularly through the PHN, also we assess those for stigma and bias. I'll try and post them in. I can only reply. I can't put a question, but we do have a question there. So, so here's a question. From a GP point of view, MBS seems to be of opinion that obesity isn't a chronic disease and hence doesn't qualify for GP management plan for chronic disease. So visits can sadly become quite costly. One of the things that the PHN might like to do then is actually invite Professor John Dixon from Monash, because I know that he regularly does a lot of education sessions around Australia to work with GPs to show them how to set up the chronic disease plans for patients living with obesity. But I think you can see from that Edmonton obesity staging tool that for anyone who has comorbidities, then they'll be eligible for the plans based on those other comorbidities. And if they don't have any, then they have very healthy genetics at this stage of their life. But even with healthy genetics, someone presenting who's asking for a referral, I think you can still refer them on. But I agree that the value of providing people support services is actually not addressed. But the other thing that I was going to say also about stigma and bias, when we were asking consumers to evaluate our online program, the other thing it sort of reminded us about was self-stigma, is that it's pretty common for people to feel that, well, they're not worthy of treatment because they should try harder. And I don't think there's very broad recognition of the genetic influences on obesity. And I was just revisiting some of that literature recently, and from twin studies, like there's been a systematic review done of 46 global cohorts on twin studies. And what it showed is that you can't get away from your genetics, particularly at the onset of obesity development. So adolescence through to young adulthood. And then I wasn't actually surprised that it showed that the older you get, the less your genetics matter, in that they didn't predict your weight status. And I guess that's because you then, maybe if you've realized that or you've gotten treatment, you're really establishing your own environment. Whereas when you're in a shared environment and shared genes, basically nature has set your course unless something different happens. So I'm just going to check the questions again. Beck, did you have anything to comment on bias, on stigma and bias?
Look, you've covered it pretty thoroughly, Claire, but something that we probably do see a lot, it's also not just the language that we use when we're talking about weight bias. It can be any range of things. And what we see a lot as well is even sort of posters of people around waiting rooms typically feature people that are looking quite fit and healthy, particularly when we're looking at sort of dietetic practices. And as a profession, it's something that we really need to be mindful of, that we're being inclusive of people of all body size, because it's all of those little things that can certainly contribute to weight stigma.
Okay, Beck, we've got some more questions, and I must be all thumbs because I can't work out how to reply to the messages. So I'm going to ask Phoebe to post those two stigma and bias questionnaires for people so they've got them. But thank you for reposting the Healthy Habits RAC GP And then there's another question. Okay, so Beck, are there supports in place once the weight loss goal is achieved?
There can be, yes. And I know it's a discussion that I have a lot of the time with patients in practice, is that the journey doesn't end once you reach your weight loss goal. But again, when we're working in private practice, and even if an individual has come in on a chronic disease management plan, we're still limited to 5 visits, which is often only enough to get us to the end of their weight loss goal, if that. So often when we're talking about weight maintenance, which is just as an important component of the management, often there's no visits left on their care plan, or they've potentially exhausted the finances that they've allocated to receive dietetic support. So it's definitely really tricky from a private practice point of view to give ongoing support to people for the weight maintenance phase.
Okay, good news. I've worked out how to reply. So I've just put those 2 links, and it's one's called the implicit association test, and the other one's called the fat shaming test. I think I've posted them. If not, I'm going to give them to Phoebe to send out. Okay, so let me just have a look. I'm scrolling down. And
did you have anything to add there, Claire? Are you aware of any other sort of support networks or anything for people once they've reached their weight loss goal for weight maintenance?
Well, no, because I think it's less recognised. But you'll remember, Beck, when we did a systematic review on this topic ourselves many years ago, and we've also looked at this in the context of kids, is that the key thing seems to be do something, like do anything, and that will improve the maintenance of lost weight. But we don't necessarily know what to do. And, I have a personal theory that maybe it's something that you would periodically do, and I know I used another analogy, and like this is a simple analogy, but I use that analogy about with antihypertensives. If you stop, well, of course, someone's blood pressure goes back up. But if you kind of think about it, if you tidy your house and it's absolutely perfectly tidy, like if you never ever pick up anything again, do you expect it to stay how it was when you finished your spring cleaning intervention? So I think with the way the environment is, there is no way you can wait for governments to introduce taxation and subsidy, to have a ban on advertising. Like, we're not going to turn the clock back to 1970, as much as that actually would be really nice to do at the moment, just to get away from some of the modern pressures. So really, it's about, for people who are seeking this information, how can we give them the information to make the choice and to know? Another example, I think, is the research that's been done, for example, on women going through menopausal transition, where when you look at the evidence, weight gain during the menopausal transition is real no matter what your starting weight. So rather than saying, well, tough luck, if women are concerned about their weight during the menopausal transition, then it's knowing, well, there's no discount for you having had a healthy lifestyle before. This is just what nature does. And the only people, the research shows, who resist weight gain during menopausal transition are people who eat more healthily and increase their physical activity. And as annoying that there is all, your healthy lifestyle before may have had no difference, it's helpful for people to know that, rather than for them to feel powerless. So that's what I think. But one of the resources I wonder if is discussed, and maybe if there's anyone there from general practice, you could give us a comment. But sometimes I think we don't realise what's available to people through their private health insurance. Like, sometimes they are, they may be concerned about their weight, but actually they've got pre-diabetes, or they've got high cholesterol, and there's actually a program available under their health insurance at no cost. And so I think people checking what health insurance they have. Of course, there are programs available through the area health service as well, but they will have longer waiting lists. But, like, the waiting list only gets longer if you don't put your name down. So I think for any practice managers on board, it might be worth, if you get constant requests for a certain type of advice at lower cost, then checking in with the community health centre in your part of the Hunter to see what's available, or finding out how long the time is. Looks like we might be having some. Looks like we might be having some challenges with that. Yeah, because when I was trying to reply, the link wasn't working. So sorry, everyone. I'm just looking in that.
Yeah, and while you're doing that, Claire, I guess another important point that when dietitians are working with patients throughout that weight loss phase, a key part of that is also we don't just educate, we build skills in being able to move on and self-manage, and teaching them how to self-monitor and to know when perhaps maybe they are gaining back some of the weight and so forth. So we really do try to build their self-efficacy as well, so that they don't need us all of the time.
Right. Okay. So I'm just responding to Phoebe. Only one of the seems I've only been able to put one of the tests in there. So I'm just going to try resending that to Phoebe through an alternative route. Sorry, everyone, that the questions are seeming to be not working as well. Let's have another go here. Okay. There we go. I think that one might have gone. I don't know. I've sent it somewhere anyway into the ether. So we've still got time for more questions if anybody is able to get any of them through the system. That's being a bit temperamental tonight. But Beck, what would be then like, given that there's so much to cover, and from those case studies, something I think we know that about 2% of referrals on the managed care plans go to dietitians. Like, for the GPs listening, what would you like to see? If there was unlimited, so essentially getting.
Yes,
okay,
yeah, definitely. And yeah, it's not, I guess the follow-up structure or schedule that I provided an example of there is something that I do often do, and often that then uses up those 5 visits. But as we've then discussed, there's no opportunity then for maybe a 6-month checkup or a 12-month checkup, just to help make sure things are still on track. And as we've seen from the Edmonton scale, there's 5 stages there. So the level of support that somebody at stage 4 or 5 is going to require is going to be far more intensive and comprehensive than probably someone at stage 0 and 1. So there are definitely particular patients that do need more support than just those 5 visits that we get.
Yeah,
and
definitely.
Often I get 2 visits probably on referrals. And I can't do a great deal with that. Yeah,
that's right. Yeah, and I think that's for all our GP colleagues listening, it is pretty hard. Like you can't be a magician with only 2 visits. But the other thing that I think is worth looking at, and I know I keep going on about the Canadian obesity guidelines, but I'm just going to tell you what some of the chapters are. So it does start with that chapter on weight bias. It looks at the epidemiology and the science. Then there's a whole chapter on prevention and harm reduction. So clinical prevention in terms of improving the health of clients. There's another chapter on enabling participation in activities. And so another chapter on mental health, pharmacotherapy. And, as you know, that's changing all the time, possibly underutilized. One of the tertiary weight management centres that was down in Monash, who were really the guru of clinical management, who in bringing people into the tertiary management setting for consideration of not just medications, but also bariatric surgery. I know some of you may have heard of Professor Joe Pareto, but he was adamant that the best place for pharmacotherapy was actually for maintenance. That was why I mentioned it earlier. But the other thing that I think is really comprehensive, and I know you've had updates on bariatric surgery before, there are 3 chapters actually on bariatric surgery in terms of selection of patients, the surgery, and then post-operative care. But I think it is exciting about some of the medications that are coming up. there's belief that one that's just been approved in the US will eventually make its way to Australia. So I think that will offer real hope for patients who haven't previously been able to get help. And all the time, those approaches, like including bariatric surgery, are most effective in line with medical nutrition therapy as well. Now, Beck, we have got a couple of questions. So this is, what do you think about light milks, reduced fat cheeses and yogurts? Are they healthier or not?
Not necessarily the healthier alternative. It comes back to the patient's goals. If I'm looking for calorie restriction and I'm looking for the easiest path to get there, then often switching from full fat to reduced fat options like dairy is quite a simple approach for people to take. So if they're open to doing that, then often when I make that recommendation, it's purely around reducing calorie content of the diet.
Somebody has put through, is Healthy Weight for Life one of the private practice programs? Yes, that's one. Some of the programs also, some health insurance also have the coach program, which is specific for cardiovascular disease risk reduction, which also does include weight management. You probably also know that in New South Wales, there's the Get Healthy line. So that's probably less intensive, but it is free, and it's a telephone coaching program from New South Wales Health. So there's many things. And I think if somebody's tried one thing, it doesn't mean they're not entitled to trying something else as well. Okay, so I'm just looking at all of those. Okay, Beck, anything else that you would like to ask me? I had one other thought. Oh, yeah. You keep talking, Beck. I'm going to put another link into the...
I need to know what to keep talking. I keep looking, seeing if there's any extra questions coming through.
Okay, so one of the things I was going to say is, we have our public program, the Science of Weight Loss, Dispelling Diet Myths. It's a MOOC, a massive open online course. And when it's running, we get the PHN to tell everyone about it. It's not running at the moment. But the other place where we publish a lot of information about fad diets and busting fad diets is for The Conversation. And it's a free online newspaper. And I would say Rebecca and I, we would have done at least 6 just on the new crop of fad diets. So that's free. You can refer your patient to that. You're only allowed to write for that if you're an academic, and it's all evidence-based information. And so, so this thing's not working again. But anyway, I'm just going to type a link to one article for Phoebe to send over to you. And this one is called 6 Tips for Losing Weight Without Fad Diets. But if you scroll to the end of that, it actually includes just some brief advice for people who are very responsive to food cues and what the science says. But again, if you scroll through the conversation, there's many, many articles on any of the fad diets that we've already written. Okay, well, we might be able to give everybody an early mark. I'll just ask Phoebe to do a check, but having said that, we need to ask her to come back because she's got some closing marks and then some information about the assessment and being able to get your certificate. So thanks for that, Beck, and we'll hand back over to Phoebe if you're ready.
Thanks, Claire.
Thanks, everyone. Sorry about the technical problems.
I just want to say a big thank you to Laureate Professor Claire Collins and Dr. Rebecca Williams for a fantastic presentation. You have both just shown just how knowledgeable and personable and interesting all this can be. Thank you to everyone who has logged on tonight and joined us. Again, it's in prime family, prime dinner time. So we do really appreciate you logging on and joining in. And just a quick reminder about the evaluation. It's really important for us to have everything evaluated. And especially for this one, because I need that information for your certificates. Thank you again to everyone and have a great night.